Do you? Okay. Do I need to do something? Oh, here we go. Can you hear me okay? All right. For those of you that know me, like Dr. Sangvi said, I'm Leslie. I work in the emergency department. I am a very easily excitable person. This is something I feel very passionate about. I will try to keep my excitement at a professional, appropriate level for this setting. But this is something that I think, from a pharmaceutical standpoint, this is one of our big changes in recent years for acute ischemic stroke. So it's worth getting excited about. I also do not have any potential conflicts of interest, nor does the facility that I work at. Historically, thrombolytic therapy, you know what, it is kind of strange. You do kind of have to stand here, Dr. Khatri, I'm with you. Thrombolytic therapy in acute ischemic stroke, historically, our standard of care, as we all know, has been alteplase. Since the mid-90s, that's what we've used. That was our only option if we were in that 0 to 3 or more recently the 0 to 4.5 time window. I'm going to read this dosing because I think the impact of how confusing and complex it is worth reading, okay? It's 0.9 milligrams per kilogram to a max dose of 90 milligrams. We give 10% of that as an IV bolus over 1 minute, and then 90% of that in its original bottle over the next hour. It comes in a 100 milligram vial, so no matter what, we have to pull 10 mLs out and waste it before we pull out the bolus, before we hang it as a drip. That's a lot of words, right? Those were a lot of steps to take to make sure we get that alteplase dose correct. If they make that at another facility and then they send them to us, did they do it right? I'd like to think so, but it's hard to tell, you know? And so there's some room for error there. In 2019, the stroke guidelines were updated to read, and I quote, "It is reasonable to choose tenecteplase as a single IV bolus of 0.25 milligrams per kilogram to a max of 25 milligrams over IV alteplase in patients without contraindications for IV fibrinolysis." That's huge. We're going to get to how that's compounded and how simple that is, but if any of the nurses in the room have done it, Alex, I'm looking at you, that it feels good. It's simple, it's quick, it's not nearly as complex as what I said to you just a moment ago. Of note, and I'll do my best, we want to call them TPA and TNK. That's what we've always called it. We've always said TPA. The Joint Commission and the Institute of Safe Medication Practices, or ISMP, really frown upon those abbreviations. I'm really trying. We've said TPA for years. TNK is not quite as familiar with that to us, but I really tried to emphasize alteplase and tenecteplase because they sound very similar and we have had med errors happen. So I'll try. Some potential benefits to tenecteplase, I've hinted at a few, but some of the more important ones, for example, safety. Worldwide safety data, and I say worldwide, the study that brought it to the forefront of acute ischemic stroke therapy was done in Europe and in parts of Australia, so not in the US. So worldwide safety data, meaning all-cause mortality, intracranial hemorrhage conversion, trends toward benefit. None of the studies that were done were powered for superiority, so we can't say it's safer, but the trend is certainly there, and I think the discussion for clinical benefit, even without a statistically significant benefit, can be made. Ease of compounding and administration. There's less exposure to healthcare workers. We're in this pandemic, you may have heard, COVID-19, and so not having that 1 hour long infusion where the nurse has to stand there and monitor the pump and make sure all is well has limited a lot of that being locked in the room with all your gear on, watching that alteplase infusion happen. It's also cost effective. Do I have a pointer? Here we go. It's also cost effective, which isn't always the case with our improvements in medical care, right? So in this case, it is actually about 30% less expensive than alteplase. Okay, the dosing. Tenecteplase historically is FDA approved only for myocardial infarction. There is a range of doses based on a range of weights. So 30 to 50 milligrams based on weight ranges. So it's not a milligram per kilogram dose like we're used to, but based on weight ranges. There was a study done in 2010, so not even really all that recent, that tested all 3 doses of what was theorized to have potential benefit in acute ischemic stroke. As you might imagine, the lower dose had less MRS score benefit, which we'll get to in a sec. meaning it wasn't as effective of therapy at clearing the clot or improving outcomes. And then the higher dose, the 0.4, increased risk of conversion. So exactly what you would have expected. The low dose didn't work as well. The high dose caused more bleeds. Of note, and this is kind of a hot topic on some of the listservs that I follow, there has been some discussion in low bleed risk patients, so patients less than 65, patients with a lower NIH scale, patients that are closer to their last known well, using this higher dose of 0.4, and it just has continued to show that increased conversion risk. So there's discussion about it. It seems like if a little works, a little more might work better. But in this case, that has not shown to be the case. So 0.25 milligrams per kilogram it is, to a max of 25 milligrams. Modified Rankin scale, this may be old news to all of you, but as a pharmacist, this was not something that I learned in school at all. And so just a really brief review of what that is. It's a 6-point scale that measures the degree of disability or dependence in activities of daily living after a stroke. 0 being no symptoms, 6 being death, and 2 to 5 being in the middle somewhere. The reason it's important, especially in our acute ischemic stroke studies, is because that's often used as a marker for efficacy. There's 3 data points frequently: the pre-admission, so how the patient was before their stroke, at discharge from the facility, and then 90 days after. So again, just a quick overview for those like me that didn't know what this was when we first started in stroke. The Extend IA TNK trial is the trial that I mentioned earlier that was done in Europe and around Australia that brought tenecteplase to light in acute ischemic stroke. It was a non-inferiority study. That means that it is designed to show if tenecteplase is, there's going to be a lot of double negatives, so stick with me, whether tenecteplase is not worse than alteplase. So it can't show if it's better, but it can show that it's not worse. Okay, so non-inferiority multi-center study in patients with acute ischemic stroke who were eligible to undergo thrombectomy. They had 200 patients. Am I going over? Is that a timer? They had 200 patients that were randomized and carried through as a 1-to-1 tenecteplase and alteplase. Clinical practice guideline dosing was used, so the same that we discussed earlier, the 0.9 milligrams per kilogram split as a bolus and a drip, and 0.25 milligrams per kilogram IV push. Inclusion-exclusion criteria matched that of standard alteplase. So if you've seen the inclusion-exclusion sheet, all the things that you have to match is what they used in this study. Primary endpoint was reperfusion of greater than 50% of the involved ischemic territory or absence of a retrievable clot at the time of assessment. The results are here. 22% of tenecteplase patients met this primary endpoint, so either had reperfusion of greater than 50% of their ischemic area or had no clot to pull out when they went in to get it. 10% of alteplase patients. Again, this looks significant, right? This looks superior, but the study wasn't powered to show that. So when we see this statistically significant number here, that means that it is not inferior, okay? Secondary endpoint, again, that MRS, 90-day post-discharge, was similar. So showed that not only was the reperfusion not worse than, but the recovery ultimately of the patient was not worse than it was with alteplase. Safety data was very similar, 1-to-1, 1 for intracranial hemorrhage or conversion. They said there was no statistical significance in the mortality rate. And I don't want to assign statistical significance where it wasn't founded, but this feels clinically significant to me. 10 deaths versus 18 deaths in the tenecteplase group versus the alteplase. So again, just helps get towards that trend that I mentioned that helps us to see that perhaps tenecteplase may be safer. In 2018, Lutheran Hospital became a comprehensive stroke center. As part of that, we have gone into and not just then, but maybe that's when I came into working with some trials, areas for improvement, things that we could do as a center to better care for our stroke patients. We did, last year, myself and one of our pharmacy residents did a study, a retrospective single center cohort study at Lutheran Hospital, where we assigned patients starting on a specific date. It was a pharmacy-driven substitution where anybody who came in and qualified for alteplase therapy would automatically be subbed to tenecteplase. Our goal was 15 patients, and we compared that to the last historic 15 patients that received alteplase. Exclusion criteria matched again that of standard alteplase, and we did not do statistical analysis. It was more of a cohort study, a smaller group, so we just looked at trends. Again, the dosing, I won't bore you with it again. Here it is. We followed the same dosing that the studies used, the tenecteplase and the alteplase in our historic patients. We followed the same clinical practice guideline-driven monitoring as far as vital signs and neurochecks after the thrombolytic that we had with our alteplase historic patients. Our primary endpoint was door-to-drug administration time. Our center goal as a comprehensive stroke center is 45 minutes or less. It has been a mountain of a goal with alteplase. Boy, we celebrated if we hit that 45 minutes with alteplase. Just all the hoops to jump through, the compounding complications, all of that. Historically, it had been a seemingly really difficult 45-minute goal. With tenecteplase, and that being our primary endpoint, 63% of our tenecteplase patients, those first 15, when we made that first switch in October, 63% were within that goal range of 45 minutes, and 20% of our alteplase, comparatively speaking, were within that 45-minute time window. If you look at the minutes, it's discouraging, right? So 69 minutes for our average tenecteplase versus 59 minutes for our average alteplase, but I think this percentage speaks volumes. We had, I can speak to, and I may discuss this on a future slide, but there was initially some confusion about the substitution and where's the drug kept, and we just had some things to learn when we first got started. And so a few of those, especially early tenecteplase patients, had some significant delays, but the average time overall, over all 15 patients, was drastically better, excitingly better than our alteplase patients had been historically. Our secondary endpoint, and this is hot off the press because we just hit 90 days just a few days ago. Thank you, Kathy. MRS 90 days post-discharge were equal. So 90 days MRS for our tenecteplase patients were 2 versus 2 in our alteplase patients, which speaks to efficacy being similar. I put the NIH here. This wasn't an endpoint that we followed, but I think it's important to note that our stroke severity was similar between the two groups also. Safety data, we had 0 conversions in either patient to intracranial hemorrhage, and all-cause mortality was 1 in 1. So again, very similar MRS, very similar safety data with an excellent primary endpoint change. It's worth getting excited about. Some discussion. Our study was conducted during that same darn pandemic of COVID-19 that I mentioned a little bit ago. What that meant for us as an emergency department stroke team is that all of our stroke patients were considered enhanced precautions or COVID positive until proven otherwise. Because we know that COVID is a risk factor, an independent risk factor for stroke. Those patients came in, we gowned up. We were all in smaller rooms. There's time involved there. So PPE donning and doffing and all of that did take some time. So I think that's just worth mentioning. 3 of our 15 patients included in the study were COVID positive. So I do think the minimizing of exposure to those nurses, to the staff that's in the room with the hour-long infusion, one-to-one. And don't hear me say that we weren't monitoring our tenecteplase patients the same, but it's different when you're pushing and you're coming in and checking vitals than if you're sitting here for an hour, being potentially exposed. And so that was a benefit for us. Time delay, again, in minutes, and I did kind of reference this a moment ago. There was some education and some provider comfort. The dosing isn't something that's super easy to reference because it's not FDA approved and it's kind of hot off the press. And so there was a lot of just double checking things, all very important things that I think in the beginning potentially led to some delays in our tenecteplase administration. But again, the greater percentage of patients in that time, less than 45 minutes, certainly speaks to less overall average delays. Safety data, again, shows no clinically significant difference between groups. We didn't do statistical analysis, but the clinically significant lack of difference is there, and that matches that of other studies, which is important. Just some cautions, some kind of things that jumped out at us that we didn't necessarily expect or see coming that we've had to work through, and we've had other centers reach out for, to speak about these kinds of things. What has happened? What did you see or observe at your site that maybe you didn't expect? The first is that the package insert, if you've seen a box of tenecteplase, you open it up and right there on the inside of the cover is dosing for myocardial infarction. If you're 40 to 50 kilos, you get this dose. If you're 50 to 60 kilos, you get this dose. And we're not following that at all. So I'm asking a nurse and a pharmacist to pull out a tenecteplase dose, verify it with their physician, open the box, and not follow that dosing. That's significant room for mistakes, for questioning. I'd question it too. Um, and I did. There was some thoughts about whether or not we could change that box if in pharmacy before we loaded it, or before it leaves our house, our pharmacy home. Can we make those changes to the box? It comes very nicely prepackaged and sealed from the manufacturer so that you know that the diluent's in there and the drug is in there and the syringe is in there. It's very nicely packaged. And we felt that the risk of breaking that seal and fiddling with it was more than the risk of those dosing confusions. So we made some house-made dosing graphics. They're everywhere. You'd have a hard time not finding one. They are in our stroke binders. They're in the kit that pharmacy brings when they mix it. It's everywhere to just reinforce that box dosing isn't what we're going to follow in this case. Another thing that this one surprised me, patient advocates now, family members, even the patients themselves, they know what they want, right? They come to the hospital. This is what is happening to me, and this is what I want. They expect Alteplase. They've Googled it, right? They looked it up on the way in, and so they want Alteplase. And so now we're going to give them tenecteplase. And so that raised some questions and some delays in getting consent and just informed consent. And so we made a simple, easy to read, frequently asked questions, just layman's terms, not medical, just, what is tenecteplase? Is it as good as Alteplase? And why am I getting it here? And it has helped a lot with eliminating some of that. The last thing that kind of snuck up on us, when you use Alteplase, it takes forever to mix, right? You got that impression from my verbiage there. It takes forever to mix. So we start early. If we have a patient comes in and they look like they're going to use Alteplase, the pressure is to start mixing it now. It's going to take 10 minutes, and I want it to be ready when it's go time, right? So we compound it, we have it ready, we have it sitting there. Tenecteplase, I can get from vial to syringe in 15 seconds, right? So the pressure to do that isn't as much as it was with Alteplase. Having said that, when we do that with Alteplase, the manufacturer has a reimbursement program. If you end up not using it, patient status changes, patient doesn't want it, family changes their mind, whatever the case is, you can send that into the manufacturer and get reimbursement. That is not the case with tenecteplase, and so just a lot of education on the idea that I can do this much faster. We may feel like there's a perceived delay, but in reality, there's not. We have wasted one since we started, and that's not the end of the world. But just knowing that same perceived time benefit isn't there with tenecteplase as opposed to Alteplase has been a bit of an education just amongst the providers and others. So what's next? I will tell you that it's the same manufacturer. The manufacturer that makes Alteplase also makes tenecteplase. So I suspect that, and this is purely speculation, I did not check this with any drug rep, I do not believe they will be seeking FDA approval for acute ischemic stroke. I'm not sure that the financial benefit is there, and not to, like I said, that wasn't a political statement. I don't think it'll happen, and so I think we need to be willing to adjust to what that's going to mean. Maybe it's education to patients, maybe it's knowing that reimbursement program is not going to be an option for us. But expecting that. At Lutheran Hospital, our tenecteplase door to needle times, can I just say for a moment, we gave it 3 times last week, all less than 45 minutes, 1 in 20 minutes. We gave it twice on the CT table. I mean, I'm not going to get excited because those of you that know me, that's my go-to. I'm very calm, but this is huge and this is exciting. And 20 and a 29, thank you. Yeah, so I mean, Luann's excited too. So we've seen huge improvements in what was a seemingly insurmountable goal before. Enough so that corporate pharmacy, so we're just our own little hospital here, but corporate pharmacy, our parent company, noticed. They have reached out to us for education for their other facilities. We've started the act of God that involves the power plan change to make it not a pharmacy substitution, but an actual workflow change that will eliminate that aspect of it. So I'm very excited for system-wide education, order set revision, and a permanent change from Alteplase to tenecteplase as our standard of care, at least within our network and within our corporate parent company. So like I said, it's worth getting excited about. Yeah, these are my references. If you want to read through them, they're very exciting. Um, yeah, does anybody have any questions? Yeah, Sherry. I think that we had one, girls, correct me if I'm wrong, I think we've given it in one. The problem with inpatients is that they often have other things going on. They've had a surgery or, whatever the case is. And so they typically meet one of those exclusion criterias. So they're typically not a candidate, but I do think we did it once. um, we struggle with inpatient stroke alerts. We're so hardwired in the ER because that's where most of our patients come that are going to be eligible for these kinds of things. And so when it's an inpatient, we struggle. But yeah, the patient, I do think we had one, but like I said, most of them do meet some exclusion criteria that eliminates them. But yeah.
I think the question is also, are you still giving alteplase on inpatients more than tenecteplase?
Not for stroke.
Not for stroke.
Yeah, no patient